This is Blood and Cancer, the official podcast of MDH Hematology Oncology. I'm the voice of MDH Podcasts, Nick Andrews. Coming up in a few weeks, Dr. David Henry and I will be in Orlando at the American Society of Hematology meeting, and we're going to bring you a bunch of content from ASH 2019. But before then, we have a preview of some of the abstracts that are going to be there, and I'm joined tonight, as I always am, with Dr. David Henry. Dr. Henry, how was your Thanksgiving holiday?
Very nice, Nick. How was yours? A lot of family. They actually went to somebody else's house this time instead of mine, but we still cooked the turkey, so I'm not quite sure how that worked.
Yeah, that's interesting.
How was yours?
Wow, that's yeah. Mine was great. It's good to see the family. I'm a huge Detroit Lions fan. They always play on Thanksgiving, so at least I got to watch them. But they're not very good, alas. That's how that goes, I suppose.
We're getting, as you said, we're getting ready to leave the cold, in my case, Northeast, and go to Orlando for a few days. And that's what Matt Kalaycio and I, the episode we're introducing tonight, he's editor of Hematology News, and we decided to kind of preview the ASH meetings in Orlando since the abstracts are out. And he's a very high-powered transplanter, and he went through several of those articles, where and when is transplant doing with what. And so I'm just a simple clinician, and I played off of his high road to my middle road of several practical, whether they be malignant, particular lymphoma, or clotting, or too much, too little anticoagulation like the DOACs, to go through about 7 to 10 abstracts, and he did 3 transplant abstracts. So it was an interesting talk.
Yeah, you know what's really interesting about going to these meetings, I think, if you take the 20 minutes, maybe even on the plane, on your phone or whatever, to kind of go through a program and pre-plan out what you want to do. And we hope that this podcast does that for you, to kind of maybe hit on something that you want to see if you're going down there. And if not, what kind of coverage to look out for from the meeting. Of course, you can find all of that information at mdh.com/hematology-oncology. So really quick, anything jump out at you that you, a talk that you really want to attend, or any data that you are excited for?
Nothing spellbinding by itself only. I think some very high-powered science in the plenary session, which ASH is famous for, and 1 or 2 clinical practical coming in with transplant. And then in the various sessions of whether it be malignant or benign hematology, some things about the new drugs to stop too much bleeding, start too much bleeding, transfusion medicine, coagulation issues. And then, of course, lymphoma, it always has a coming out party at these meetings, and this is no exception. One of the things I talk about on the podcast with Matt is the new CD47 antibody that was approved for diffuse large B-cell intermediate grade, now has this wonderful study they're going to present in low grade, usually the follicular Hodgkin's lymphomas, and very good results as well.
So that is coming up later in the interview portion of the show, which is a preview for the ASH 2019 meeting. Also, you can tweet at me at Nick_Andrews, and you can tweet at Dr. David Henry. All that Twitter information is available in the show notes. If you have food recommendations in Orlando, I am quite interested. I like fresh fish in Florida, and if you want to come say hi, maybe get on the mic and just give a colleague or a mentor a shout out, we would love to see you if we can run into you down there as well. It's time to talk about Dr. Ilana Yurkiewicz and clinical correlation. Something really important. It seems to me that geographically speaking, hospitals are not a bad place to be during the holidays. There's a lot of decorations. There's a lot of festivity. It feels like perhaps a warmer environment than maybe it does all the time. But Dr. Yurkiewicz wants to talk about isolation, particularly this time of year whenever a patient is diagnosed and going through a chronic illness.
Yeah, I think especially the holiday time, you're not happy if you're fighting in the middle or beginning or end of fighting a cancer, some kind of chronic illness, and all the commercials are about someone gets 2 cars, 1 for each spouse, and it's all happy. And I think this can be a very sad time for some people. And so whether you're in the hospital for this, and it's a different feeling from when you had holidays at home, or just fighting an illness or down on your luck, you can feel isolated.
Yeah, and she does a great job of chronicling this, as she always does, in the human side of hematology oncology care. That's coming up after Dr. Henry's conversation with Dr. Kalaycio. But it's time now for This Week in Hematology and Oncology, and we really are living in the time of the chronicled immunotherapy. The FDA has a new approval. The FDA has approved Atezolizumab in combination as first-line therapy for advanced non-small cell lung cancer. That is specifically for non-squamous metastatic non-small cell lung cancer with no EGFR or ALK genomic tumor aberrations. You can read more about the data that led there, but Dr. Henry, this is we're living in the time. I feel like I'm going to read a book one day about all of the approvals and all of the different therapies and combos.
Yeah, living. They'll say, "Were you there, Grandpa, when this happened?"
Yeah.
And we were. And I refer our listeners to the two-part interview we did with Jack West, from the West Coast, California, specialist in lung cancer, and talking all about chemo antibody, or either one alone, and the role they play, which is increasingly popular and effective.
Yeah, and would you take a quick look at the data that led us to this, if you don't mind? Phase 3, of course, the median overall survival for advanced non-small cell lung cancer patients who received the therapy was 18.6 months compared with 13.9 months. So again, we're making strides.
And let me correct, I just realized I misspoke on the Polatuzumab. I said it was CD, the wrong number. It's CD79 antibody, in case our listeners were
they would have caught you, of course.
Wrong number is CD79 antibody.
Okay. So send those angry letters to Dr. Henry's house, if you don't mind.
Thank you.
So
I look forward to that.
You can find more information about the trial that led to the approval. It's IMpower 130 trial. The link is available in the story. And for news like this, you can always log on to mdh.com/hematology and oncology. Well, David, I'm pretty pumped to go to Orlando this time of year. It's getting pretty cold in Philly in the Northeast. And I kind of want to try swordfish, I think.
And I peeked at the weather, Nick, and it looks good. Nothing going to prevent us getting there. It's happened once at Ash in Philadelphia. It was a snowstorm. They didn't do that anymore. And the weather getting home looks to be good also. So hope those who are listening might be going, and we'll see you all there.
All right. Thanks so much. Stay tuned for Dr. David Henry and Dr. Matt Kalaycio.
Thanks, Nick. Welcome to this podcast. You are listening to Blood and Cancer, a podcast which comes out weekly and can be found and subscribed to wherever you get your podcasts. And we are online and on the online journal called mdh.com/hematology-oncology. And we try and bring you each week interesting hematology, oncology, blood and cancer papers, presentations. And this week, ASH, the big American Society of Hematology meetings occurring in Orlando. Those of us in the Northeast, a welcome change. Hopefully we can get in and out with the weather. And I'm delighted to be joined tonight with Matt Kalaycio, who is just stepping down as chairman of hematology oncology at the Cleveland Clinic, replaced by James Abram, so that Matt can do more and more of taking care of patients and making the field move forward. So Matt, thanks for joining in on this pre-ASH possible update.
No, I'm glad to do it. I'm excited for the meeting.
Yeah, me too. It's always very exciting that the buzz and what's happening, what's new, and what will be the game changers as we come out of the meeting. And so you and I looked over what's going on and what might be interesting as we go in, based on some abstracts and presentations, and of course plenary papers that always are supposed to be the best. Although I must admit, not always titles I can decode. And so, having said that, I'm going to give the microphone to you first, because I know you're going to review 3 abstracts coming up that are pretty intense, pretty high level, and people like me need to know all about. So take it away.
Sure. So I am, first and foremost, a bone marrow transplanter, and that's where my eyes go first when I'm reviewing abstracts for the annual meeting. And this year, the very first abstract is a plenary pick that has to do with transplant. And I thought I'd review that because there's some things about it that the general hematologist may not be aware of. And I think would be interested to know why this particular paper was picked as a plenary. So the idea of giving cyclophosphamide after transplant, after an allogeneic transplant, makes little intuitive sense. But the group at Johns Hopkins University has pioneered this approach as a mechanism to allow for transplants from mismatched donors. Not completely mismatched, but half-matched donors. We call those haploidentical transplants. So by giving cyclophosphamide on day 3 and 4 following an allogeneic transplant of someone who is half-matched, the donor graft not only grows, but the risk of graft versus host disease is significantly abrogated, and patients have survivals that are very similar to results that we get with matched and unrelated donors. So
a half match that does just as well with the Cytoxan. Amazing.
Right. Yeah, it is amazing. And it has expanded the pool of available donors, especially for minorities minority patients who don't otherwise have a match. So it's been a tremendous advance. But the fact that this works in half match, this post-transplant cyclophosphamide, begs the question of whether or not it might be a better graft versus host disease prophylaxis for matched donors. And that's what this first plenary paper looks at. It's a randomized trial of patients who are undergoing allogeneic transplant with a matched related or a matched unrelated donor and testing standard GVHD prophylaxis versus this new technique of post-transplant cyclophosphamide. The results, I'll just skip right to the outcome, which is why I got a plenary paper before dissecting it. And the conclusion is that by using this technique, results are similar in terms of relapse and survival, but there's reduced risk of graft versus host disease, chronic graft versus host disease with post-transplant cyclophosphamide. And that observation is what prompted this plenary pick. This is the way the field has been going. There are some phase 2 trials that show basically the same thing, and more centers are picking up post-transplant cyclophosphamide as their standard graft versus host disease prophylaxis. Now, there's some problems with this paper. It's not perfect. So, for example, the control arm uses cyclosporin and mycophenolate. That's not the best graft versus host disease prophylaxis. Tacrolimus, or FK506, plus methotrexate is probably a better combination. And in the experimental arm, the post-transplant cyclophosphamide was not combined with mycophenolate as it usually is and has been pioneered by the Johns Hopkins group. It's a relatively small trial, only 150 patients. And there's some heterogeneity with regard to whether what kind of prep was used, what kind of stem cells or versus bone marrow were used, and I could go on and on about those little details. But importantly, there was a non-significant increase in the relapse rate with the post-transplant Cy at 3 years, and I'm not sure that's long enough follow-up to conclude with certainty that post-transplant Cy is just as good as the other prophylactic regimens without worrying about relapse. So I'm not convinced that this changes practice. And I think a better study is out there and open for accrual right now. And that is the Bone Marrow Transplant Clinical Trials Network Study 1703, which is a randomized trial of this technique versus tacrolimus and methotrexate in the same idea, but using, I think, better control and experimental arms, just a little in a larger study that I think will answer the question finally.
So it's a great first step with a fascinating possibility for haploidentical people.
Right. I think it will change standard practice, but I don't think it's changed standard practice yet.
Okay. All right. We got to be there. We'll listen to it.
How about that? So there's another abstract. This is number 261, which looks at a pediatric-inspired regimen for the treatment of Philadelphia chromosome negative acute lymphoblastic leukemia. This regimen, I have no other way to describe it except as CALGB 10403, is a induction regimen, a complete regimen for ALL that it uses a lot more L-asparaginase than we would typically use in an adult population. And this trial was done in patients up to age 40 years old, so applicable to an adult hematologist practice. This trial has been reported But in this particular abstract, they took the reported results and compared those results to a similar population of patients that were reported to the CIBMTR, which is the Center for International Bone Marrow Transplant Registry, who ultimately all of those patients get bone marrow transplants. So what they're doing is comparing this intensive regimen, which typically doesn't include transplant, versus a population of patients who did get transplant over a 10-year period of time and seeing how things shake out. Now, there are all kinds of problems with using registry data, and it shows up in this particular abstract. So even though the results were better with the pediatric-inspired regimen, I don't think that this is the death knell for transplant in CR1 for patients with pH-negative ALL, because we don't know a lot about the high-risk patients. There's no information here about those with translocation 411. There's no data with regard to minimal residual disease or Philadelphia chromosome-like signatures. And it's important to understand that some of those patients, as many as 20% on that study, on the chemotherapy study, went on to BMT and ended up being excluded from this analysis, which would obviously bias results towards chemo. So an interesting analysis. I think that regimen is the way younger patients with ALL should be treated, a regimen much like that one. But I don't think we can completely exclude transplant from consideration in CR1 on the basis of this particular analysis.
Okay.
Finally, I've got another one I like. This is abstract 322. This is a review, an updated analysis of a study reported a long time ago by Isakuri at the MD Anderson Cancer Center. In this particular trial, he's just comparing their results with autologous versus allogeneic transplant for follicular lymphoma. And as has been reported before, it turns out that there is an improvement in progression-free and overall survival with allogeneic compared to autologous transplant for follicular lymphoma. But what caught my eye were the Kaplan-Meier curves attached to that abstract. This is where podcasts sort of don't lend themselves. But I will tell you that if you looked at abstract 322, there are no plateaus to either curve. This is with 10 and 12 years of follow-up, suggesting that there is, in fact, no cure with an allogeneic transplant for follicular lymphoma. And with all the newer drugs available since that study began, it's hard to know when to offer an allogeneic transplant, if at all, if we can't cure it. So this is just so that people just don't think I'm completely biased, that I think this abstract does point to a problem with using allogeneic transplants for follicular lymphoma if the goal is cure, because I see none based on this abstract.
So as we've been taught for years now, these patients relapse given enough time, and so as you mentioned, the curves keep going down.
That's right. And there's the inherent comorbidity that comes with it of chronic graft versus host disease.
Oh yeah.
So I would have, based on this, I would have a hard time recommending allogeneic transplant for follicular lymphoma, and especially before other things have been used. And then you look at abstract, like the other plenary paper that caught my eye for malignant hematology, using a antibody construct that is similar to the bispecific T-cell engagers, a entity called Atezolizumab, I think I pronounced that right, and that showed activity for follicular lymphoma, that where other T-cell constructs like chimeric antigen receptor T-cells haven't worked as well. So I think there is something to T-cell immunotherapy for follicular lymphoma, but I'm not convinced as at the moment that it's allogeneic transplant.
Yeah, I couldn't agree more. I agree, and I think I keep seeing this relapse no matter what. And of course, if we can't get a cure, why would we put
You're right.
this? But of course, someone had to test the question, and here's the abstract to hear the answer.
I think so.
All right. Well, very deep, very high level. I'm going to take us on down to the more common and practical world and see what you think, and you can kick in as you like. So
Okay.
I'm beginning with late-breaking abstracts 5 and 6. So of course, they're late breakers, so the reviewers think these are something people should know about. The first one is late-breaking abstract, or LBA 5. I'll read the title. Validation of BCL11A as therapeutic target in sickle cell disease results from the adult cohort of a pilot feasibility gene therapy trial inducing sustained expression of fetal hemoglobin using post-transcriptional gene slicing. And really, as complicated as that title sounds, they report 3 patients with sickle cell in whom they did ex vivo alteration with a lentivirus similar to the CAR T phenomenon of their cells and put them back in with this particular molecule, the BCL11A, and managed to turn those cells back on to produce F. And this engrafted, it was tolerated. Of course, it's very high level, expensive, experimental, but as I think we'll hear a lot at these meetings, sickle cell face of that disease may be changing either in symptomatic control or changing those patients' sickle into non-sickle cells. So that's LBA 5, and LBA 6 is titled Carfilzomib, Dexamethasone, Daratumumab versus carfilzomib and dexamethasone for the treatment of patients with relapsed or refractory myeloma. And this is a randomized open-label phase 3. And really what this is just one more regimen. Here, a proteasome inhibitor, the usual DEXA, and the antibody daratumumab, showing that you can capture and put in remission even refractory relapsed myeloma patients with this K small d capital D regimen. And the progression-free survival was superior, of course, with the 3-drug and the 2-drug. Okay.
So, David, may I interject? I find studies like this one sort of obvious. It seems to me that this is, why would you think that why would you think that adding daratumumab wouldn't improve progression-free survival? And I wonder, when these studies when someone decides to do them, there's a lot of resources that go into this. Asking a question that's I'm not so sure needs to be answered. And it gets to be a late-breaking abstract, and everyone gets excited about it. But I've got a little bit of a problem with the resources that would be required to conduct this trial, for which the answer is, I think, pretty much already known.
It's an awfully good point, because the control arm, or in this phase 3 open label, is just the 2 drugs versus the 3 drugs with the daratumumab. So It's predictable. It gives us more tools, but only for patients who fit this study. And exactly right, you could predict this will happen. And I hope we get some algorithms of how to use all these drugs we now have available. Selinexor just approved, venetoclax. Where
absolutely
them in
agreed.
I have a patient just right now who's in like 3rd line, and what do I do next? And I call people like you to tell me.
Well, I don't think this particular abstract is going to answer your question for you.
All right, deal. All right, good. Next, we go a little deeper, 1588. And this was a trial I was actually involved with, and here's the title: Safety and Efficacy of Brentuximab vedotin in combination with AVD in stage 2 to 4 HIV-associated classical Hodgkin lymphoma. Results of a phase 2 study. Our presenter is one of our main guys in the AIDS Malignancy Consortium named Paul Rubenstein. And basically what this shows is it works. It's very effective nowadays with very good antiretroviral therapy. Our HIV patients are doing and should do, as well as others with our malignancies, in this case, Hodgkin's. The 2-year progression-free estimate was 86%. The caveat here, of course, is who's on more drugs than the HIV cancer patient. They're getting older, so they got diabetes, hypertension. They're on their antiretrovirals. Then we give them chemotherapy and growth factors. So it's a lot of drugs. And the caveat is the CYP3A4 inhibitors can lead to drug-drug interactions. So your pharmacist will tell you what not to use. The take-home is, please use integrase inhibitors in these HIV cancer patients, least interaction.
Good point.
The next one, a lot of my career has been on growth factors and supportive care, and so anemia of cancer. And here was this is in mice, exploratory research study, abstract 940, elucidating the role of IL-6 in erythropoiesis and in the development of anemia under inflammatory conditions. And here the authors just go through a number of mechanisms leading to targets like IL-6, like hepcidin, to abrogate, decrease, improve, without using transfusion or ESAs, some of the anemia of inflammatory disease like cancer. On to CML, abstracts 26 and 27. So 26 says, introducing a predictive score for successful treatment-free remission in chronic myeloid leukemia. And so, as you know, the past couple of years, they've wowed us at the meeting saying, well, patients are getting tired. I really don't understand that, because it used to be awful. Patients are getting tired of taking a pill a day. Could you stop it? And so some just simply voted by stopping, then trials were done. And roughly, I think we are hearing 50% will not relapse. This first trial, abstract 26, says, introducing a predictive score for successful treatment-free remission in CML. So age, previous TKI resistance, duration of major molecular response, and transcript type. And they will, I think, give us an algorithm in this presentation, can help you hedge your bet as you're discussing this with your patient. And going along with it, number 27, a report on 114 patients who experienced treatment-free remission in a single institution during a 15-year long-term follow-up. And they found that patients experiencing molecular relapses, about 17% of these relapses occurred after 2 years. Now, I'm remembering from meetings, you can correct me, Matt, that usually in months, maybe 6, you have to see them every month, they're going to relapse. Here, late relapses in some 17% at 2 years. So you can't stop following.
That's right. Usually usually the relapses occur very quickly in the first 6 months, but there's a few stragglers that come along in the second 6 months. And this 17% long-term relapse rate, at least with the available follow-up, doesn't really surprise me too much. Some of these just have slow growth, and we know that you need to continue monitoring these patients. Even with the Irish trial, we had late relapses at 10 years. Even in patients who had deep remissions at one point, on continuing therapy. So it doesn't surprise me a whole lot that there's been late relapses. I suspect with time there'll be even more, but that doesn't mean we shouldn't try to proceed with treatment-free remissions, particularly when you look at the prior abstract you were talking about in that population of patients who have a better than 50% chance of achieving it.
Yes. And so I think there's that cohort, there's that group where you can stop and they will go on, but don't let your guard down as long as 2 years. So this next abstract 57 is for our listeners who want to take this to their blood utilization committee, because it's an obvious, but here's data to support. And the title is abstract 57, Patient Harm from Repetitive Blood Draws and Blood Waste in the ICU, a retrospective cohort study. And no surprise here, of course, they show with nice data that patients in ICU have tremendous amounts of blood draw. Many, some percent, large percent sometimes, is really not indicated to keep knowing this. And so you're taking out and then giving back because you have to transfuse. So this would help practitioners, blood utilization committees in trying to dial down some of the repetitive blood draws because they're not all necessary. Number 59, kind of the other way around for anemia. This is entitled Impact of Iron Supplementation on Patient Outcomes in Women Undergoing GYN Procedures, Systematic Review and Meta-Analysis of Randomized Trials. And we do this often in our group. We have a very large bloodless / Jehovah's Witness following at our Pennsylvania hospital. And so they've kind of taught us how to do better blood management, IV iron into people, in this case women with GYN procedures, to be proactive. And they review in their review of studies that many of these women get proactive IV iron if they're undergoing surgery or anticipate a long hospitalization, to decrease the need for transfusion and increase the outcomes anemia. So again, an obvious but very nice data set to have. So shifting from supportive care anemia more back to oncology, here's abstract 126. So I saw with interest, I think late summer, polatuzumab got approved, polatuzumab vedotin in intermediate diffuse large B-cell. Here's abstract 126, polatuzumab vedotin plus obinutuzumab and lenalidomide. So a 3 combination in patients with relapse refractory follicular. Here's on the heels of your follicular comment.
Right.
Primary analysis of the full efficacy population in a phase 1b/2 trial. And the top line result is, this is being presented on Saturday, and I think I said 126 abstract, oral session, very effective in this low-grade non-Hodgkin lymphoma, similar to the results where polatuzumab found FDA approval in the intermediate grade category of in non-Hodgkin's diffuse large B-cell. So that's nice. So we'll hear about that, and maybe we'll get a label for that in the near future.
Yet another treatment for follicular lymphoma that does not cause graft versus host disease.
Z, like you just said. Yeah, absolutely.
Right.
So please, listeners, keep that in mind. Okay, on to sort of a cousin in malignancy, P. vera. Abstract 126. Risk of hemorrhage in patients with polycythemia vera exposed to aspirin in combination with anticoagulants, results of a prospective multi-center observational cohort study. And one of my former, and this is Abstract 168, oral presentation on Saturday afternoon. One of my former mentors, Jerry Spivak, warned me about the very high hemoglobins or platelet counts, especially platelet counts. You can get acquired von Willebrand's disease. And so just giving aspirin because you see a high platelet or a high red count may not be a good idea. And here in this study called the REVEAL study, aspirin and anticoagulant in patients who had, for example, VTE could lead to increased bleeding. So be careful, and would have a low threshold to checking for acquired von Willebrand's, especially the platelet count is getting to be 1 million or higher. Now, on to the same theme of VTE and treatment. Here are a couple on cancer and treatment of venous thromboembolism and using our new DOACs. So 326 and 327. 326 title, Safety and Effectiveness of Apixaban, Low Molecular Weight Heparin, and Warfarin among venous thromboembolism patients with active cancer, a retrospective analysis using 4 U.S. claims databases. And these trials that sometimes present huge numbers looking at claims-based, looking backwards, oral presentation. It is Saturday afternoon. And their top-line conclusion was the DOAC was just as effective with same or less bleeding than low molecular weight heparin or warfarin. In kind of a companion, which I guess will probably be right after it, oral presentation 327, safety and effectiveness of apixaban, low molecular weight heparin, and warfarin among venous thromboembolism patients with active cancer, a subgroup analysis of VTE risk scale. And they have the same conclusion, but they're going to show us, not clear to me in the abstract, how you might decide a little better dose and duration in a patient population with cancer and a venous thromboembolism risk. I'm always thinking of the Carana scale. You have a patient, almost every time I see a pancreas cancer patient with liver metastases, the Carana score is high, and I try and be proactive in that patient. And we're developing data on using the DOACs there as opposed to Coumadin or shots of low molecular weight heparin.
It's exactly what we're doing here. Dr. Carana's office is next to mine, and we've integrated. We've integrated his score into our electronic medical records, which screens every single cancer patient. And those who are high risk, we screen with ultrasound and get them started on DOACs, even if there are incidental thromboses identified.
Yeah, I think he's made a major contribution. Please get me an autograph if you can. It is field using these molecules and predicting who's at risk, because the overall line I remember is 20% of metastatic cancer patients through the course of their illness will get venous thromboembolism. It can be mortal. So prevent. Now, that leads to what you sometimes get from house staff. Patients CNS malignancy, what about using the DOACs? In them, will they bleed? And my thinking has always been, absent melanoma or germ cell, which tend to be rather bleedy in the CNS, the answer is no. And in fact, that's what this 1160 abstract, safety of DOACs in patients with CNS malignancies, concluded. It's just as safe as low molecular weight heparin and possibly less bleeding. So that's nice. And I think I have one more. Yes, so abstract 566, phase 2 study of oral rigosertib combined with azacitidine as first-line therapy in patients with higher risk myelodysplastic syndromes. I don't know about you, Matt. I am seeing, as patients in our population age, I'm seeing more and more myelodysplasia. There's more and more prognostic scores, the IPSS or IPSSR, and what to do with them once you get past growth factor support. And here, this rigosertib is a RAS mimetic. So we think of KRAS. This is a RAS mimetic that binds RAS binding protein in a RAS effector model inhibiting PI3 kinase and a PLK cellular signaling pathway, and may therefore open up more production of red cells, so treating anemia in this population. This was abstract 566.
Yeah,
So
I think this is agreed, and I think this is just as much of an advance as the addition of venetoclax has been to azacitidine for AML in patients with these high risk neoplasms. This is another one that looks really good.
And I should mention, I looked at my notes here, 90% response rate. We're talking now about this molecule and azacitidine, and 30% transfusion independence in high-risk MDS groups. So I know I'll be in the audience for this one. This is an oral session on Monday morning, 7:15.
Right. Now, the transplanter in me will say that this is great, get them in remission, but don't forget to send them to us. Because this is not a cure. This is just gets them in remission, makes them feel better, which improves their chances with the transplant.
Awfully good point. Because to give, I've used the garden analogy for years. The red cell, white cell platelet flowers in your soil. Everybody's sick, and so you just need to give a new garden, and that's what you do.
Yeah.
So I think I've covered mine. You've covered yours. I know we're both looking forward to this meeting, and we'll come out of it with some exciting news and maybe some top-line reviews down the road. So,
sounds great, David. I look forward to seeing you down there.
Likewise, and of course, the 80 degrees won't be hard to take either, so
we'll live with it.
Should have a great meeting, and we'll report back. You've been listening to Blood and Cancer. I'm delighted to talk with Matt Kalaycio at the Cleveland Clinic, and you can find us online, mdedge.com/hematology-oncology. Please download us, please listen, and comment, review, and thanks for listening. Thank you, Matt.
Thank you, David. Take care.
I'm Dr. Ilana Yurkiewicz, and this is Clinical Correlation, a segment about the human side of hematology and oncology care. Today, I'd like to touch on the isolation that comes from dealing with chronic, serious illness, either personally or in a loved one. I am privileged to see every day patients who are dealing with cancer. Cancer, of course, is one such condition, but there are many. And especially around the holidays, I'd like to address this segment to people who perhaps don't have the experience dealing with chronic, serious illness, and how you can show kindness to those who do. Perhaps one of the hardest parts about dealing with illness in a public, everyday social setting is the assumptions. People make assumptions constantly. They might say, "So you're seeing your parents for the holidays?" Which can sound like the most benign comment, not knowing that maybe your mother is on hospice and of course cannot travel. The casual, everyday small talk assumptions that assume things are going well for you and your loved ones can be draining, painful, repetitive, and make you feel incredibly isolated. The burden shouldn't be on you to explain when things aren't going so well, but so comes the added hit of having to explain. Then come the remarks that don't show the right empathy, or more commonly are dismissive and just don't get it. This kind of isolation is actually incredibly common because chronic illness is very common. The isolation that you feel is not just yours to bear. I encourage my patients as often as I can to join support groups with others who are dealing with similar things. These can be validating and way more helpful than hearing misplaced sympathetic statements from friends who don't get it or doctors who see you for 10 or 20 minutes. For everyone listening, especially as we're in a holiday season, I just want to remind everyone that in your everyday small talk, you don't know who's dealing with what. I hope we can all remember to show kindness to one another in all of our assumptions and all of our encounters, big and small. Thanks for listening, and I hope you'll tune in next time for Clinical Correlation.